Okay, I think in the interest of time, I am going to get us started. So welcome to the Neonatal Hemodynamics Targeted Neonatal Echocardiography Neonatologist Performed Echocardiography Foundations curriculum. We are supported by an unrestricted educational grant, and there is accreditation through the Royal College of Physicians and Surgeons of Canada. And we really do take your session evaluation seriously, and we make changes based on those. So please go ahead and take down the QR code. So open up the evaluation now so that you have it readily available for you at the end of the session to fill it out. I'm going to leave this up for just a bit longer. And so I want to remind everybody of a few housekeeping items. Those that are panelists, keep your audio off unless you're actually asking a question. You can have your videos on or off throughout the whole session if you'd like to kind of have that more personal interaction, but we just don't want the audio interrupting the speaker unless it's actually a time when you're having a question. If those in the webinar, if you do have questions, there will be a Q&A session after this initial talk. Please put those questions in the Q&A box. There is also a chat box, but the Q&A for your questions would be much more helpful for our speakers and for us moderating. And then just a reminder, this is a monthly session. Next month, we will have congenital heart defect and anatomical lesions discussion with Dr. Stephanie Acosta and Dr. Jose Aldana. So please join us then. But for now, let us get started with today's session, which is on pulmonary vascular disease and pulmonary hypertension. So Dr. Nidhy Varghese is the medical director of the Texas Children's Hospital Pulmonary Hypertension Center. She's a practicing pediatric pulmonologist and is a passionate ally for patients and caregivers. In addition to pediatric pulmonary hypertension, her interests lie in pulmonary vascular disease complications of developmental lung disease, bronchopulmonary dysplasia, and sickle cell disease. Carolina Michel is an attending neonatologist at Hospital Ángeles Centro Sur, Querétaro, Mexico. She completed her neonatology training at Instituto Nacional de Perinatologo in Mexico City and a fellowship in neonatal hemodynamics and clinical research at Montreal Children's Hospital. So her research interests include NERS in congenital heart disease, the preterm heart, and pulmonary vein stenosis. So the two of them will be doing the first part of this, which is the 30-minute lecture, and then we'll have a Q&A for both of them. So I am going to go ahead and stop sharing and turn it over to the both of you. And thank you so much for joining us.
Thank you. Thank you, Danielle. Thank you, all of you, the organizers of this conference, for the opportunity to speak today. And Dr. Michel and I got a chance to meet each other, which was also very exciting because we had not met before. So it was really wonderful to be able to meet another colleague who was as passionate about pulmonary vascular disease in the neonatal population as I am. And we have a joint presentation that we'll be doing today for all of you. Carolina, do you want to say anything before we get started?
Yes, thank you. So thank you for the opportunity. I'm very happy to work with Nidhy with such an expertise. I'm just more like a fan and passionate about PVS, but hope in Mexico we start to do more about this. So thank you.
Okay, well, so with that, let's go ahead and get started. So as I said, Carolina and I have done this presentation together. So what we plan to do is really just kind of take turns at different parts of the presentation to go through the slides. Carolina's driving the slides. So if you wouldn't mind, please, next slide. All right, so these objectives were given to us by the organizers of the conference, and they were so good, I didn't feel a need to change them. So the objectives for today's talk are to examine the indications for why a neonate or an infant would be referred to the cath lab when we would think about a hemodynamic assessment, especially in the context of pulmonary hypertension, which I'll refer to as PH for the majority of the talk today. interpret the hemodynamic data obtained during catheterization, and this includes all the measurements that you see listed here. And then finally, learn and to recognize left-sided phenotypes such as pulmonary vein stenosis and other etiologies of post-capillary pulmonary hypertension, and review their management strategies. So let's go ahead and get started. So first, just to orient everybody, there are 5 groups of pulmonary hypertension. Group 1 is pulmonary arterial hypertension, and this is all the different types of pulmonary hypertension as you see listed under that. Group 2 is pulmonary hypertension due to left heart disease, or rather post-capillary disease. Group 3 is pulmonary hypertension due to lung diseases and or hypoxic conditions. So a lot of the respiratory disorders that we see in the NICU, or I see as a pulmonologist, will fall into this group. Group 4 is pulmonary hypertension due to pulmonary artery obstructions. It's chronically thought of, this group, that this is the group of pulmonary emboli, so thromboembolic pulmonary hypertension, also abbreviated as CTEPH. But other pulmonary artery obstructions, such as a segmental pulmonary artery stenosis, could also fall into this group. And then finally, group 5 is kind of our NOS group, our generalized group, multifactorial group, our NOS, I don't know what it is group, and syndromes and things will fall into this group too. So there are 5 broad groups, and these 5 groups are based on pathophysiologic mechanisms, clinical presentations, hemodynamic characterization at the time of cardiac cath, and then responsive therapeutic management. So some of the grouping seems a little random or perhaps inappropriate at first blush, but when you look at it in more context in terms of these different grouping guidelines, you understand that these are all come together. And the one that we're going to focus on here today is group 3, which is pulmonary hypertension due to lung disease and or hypoxia. This is the group that is growing most quickly in pediatrics. And as neonatologists, this is the group that comes across your pulmonary hypertension radar more frequently. Next slide, please. So pulmonary hypertension really exists along a spectrum. And this is a table from the European Society for Cardiology and the European Respiratory Society that was published in the ERJ a couple of years ago. And I apologize, I forgot to put the reference for this on the slide. I can certainly provide it if people are interested. But I love this table because it really highlights that pulmonary hypertension is along a spectrum of life, and that the way pH presents in infancy can look very different from how it presents in childhood and adulthood. And our comorbidities, our risk factors, how we diagnose, the therapies that we utilize, and then also how we classify all change based on where the person is in their life journey. So I'm going to call attention to the far left, which is the infant portion, infant column. And as you can see, there are 5 groups of pulmonary hypertension, and pretty much there are 4 groups listed right there as reasons that an infant would have pulmonary hypertension. And the 5th group is left blank. I would submit that the 5th group would be things like trisomy, the trisomy 21, 18s, even 13s. Other chromosomal abnormalities, and they can also be in group 5 because it's a multifactorial type of pulmonary hypertension. But as you can see, our therapy often tends to be working on respiratory support. And that's because group 3 disease, which consists of developmental lung diseases such as BPD, CDH, and alveolar capillary dysplasia, really tend to dominate the landscape for pulmonary hypertension in this age group. Next slide, please. So pH, what does it look like in the NICU? And this graphic here is from a paper that I authored with Gabe, who I think was not able to make it today for the call, Dr. Altid. But this is for pulmonary hypertension in the BPD infant. But a lot of these screening mechanisms actually would show up or would be utilized across other types of developmental lung disease. And I apologize because I'm just realizing my boxes at the top are all empty, and none of the headings came through. So if I can remember correctly, the first box on your left said PPHN. The second one said developmental lung disease. The third one was airway-related hypoventilation, and the fourth one is non-CDH. No, sorry. The fourth one was I cannot remember. Oh my goodness. I can't remember what my fourth slide was. I'm so sorry about that. So this just did not come out right. But my point in saying this is that screening is important. So you can only diagnose pulmonary hypertension in the patients in whom you think about pulmonary hypertension, right? So this is a screening algorithm that is proposed for use in the BPD infant, the infant who hits 36 weeks of age. And now you're wondering, have they developed pulmonary hypertension? And I put all this in here because it gives you a sense that you really need to be thinking through every step of pulmonary hypertension, every step of the patient's respiratory status and support, and also where the patient is in terms of their overall general health and stability. So this type of assessment that we use for BPD can in many ways be applied across the board for CDH, non-CDH lung hypoplasia syndromes, in the sense that screening is important for everyone in whom PH is a risk. Next slide, please. Go ahead.
So,
this one I'm going to defer to Carolina.
Yeah. So we know in our population, in our NICU population, bronchopulmonary dysplasia is very prevalent. So I just want to point out that there is a profound morphologic disruption affecting all components of the developing lung, including the alveoli, airways, vasculatory interstitium, and notably also veins and lymphatic vessels. So normally our clinical attention has frequently centered on changes in pulmonary arterial circulation, such as, oh, how is the resistance? The resistance hasn't dropped and there's elevated pressure, but we have to keep in mind that it's important to remember that all the components, such as the veins, are also affected. So in our population, we see that we have like long hospital stays, so multiple dose-dependent risk factors start adding up. So this is common in particular in preterm infants. So these factors, which we will discuss later, often add as secondary and compounding insults on the top on the underlying the morphologic disruption. So this is what we call like a second hit. So here, just as Nidhy will also point out, like how is the classification, I just wanna like put it how is in pediatric pulmonary venous obstruction. We see here that PVS associated with pulmonary, with prematurity and lung disease is here. And we can see in this diagram, I also put this reference at the end, but this article from Children is beautiful for knowing the risk factors. We can see here that there's a population with PVS that almost all the time we have the severe BPD, PH, and prematurity, but also there is population that doesn't have those characteristics. So it's really interesting because there's still some unknown risk factors.
Thank you, Helena. Picking back up now, so talking about what these diseases look like, they can be very abnormal, and unfortunately, sometimes they're not, based on a plain film, readily discernible. Oh, we lost the...
Sorry.
No, it's okay.
I don't know what happened here. Oops, yeah.
There you go. Thank you, Adelina. So as you can see from these plain films, sometimes it's not readily apparent what the child is actually going through. And that's where seeking a CT scan of the chest can be very helpful. These are some slices that we used in a paper that was written. These were provided by Dr. Gillerman. And as you can see here, acinar dysplasia and alveolar capillary dysplasia. At first blush, I don't think it looks horribly different. I mean, if you look at it more closely, if you're trained at looking at chest x-rays and you really do increase the size of this, you can see that the interstitial prominence is actually a little bit different. In the alveolar capillary dysplasia, it's more of a sheet, whereas in acinar dysplasia, you can see that there is really a granularity to it. So that is the differentiating characteristics, but it's not obviously apparent at first evaluation. But if you look at the lower panel with the CT scans, there are marked differences in these infants with surfactant protein B, BPD, and filament A, which so this really highlights that CT scan should be considered as part of the imaging across the diseases to help you understand in this patient with group 3 pulmonary hypertension, what is really happening at the architectural level of the lungs, and is that contributing to the phenotype that we see? Next slide, please. So when do we refer patients to cath? And so we thought that this might be kind of nice to look, compare and contrast. So why do I bring up the word cath in the NICU? And then why does Carolina, as a neonatologist, when does she think about like, hey, maybe I need to consult somebody for a cath? So for me, as a pulmonary hypertension pulmonologist, if I have someone with a recurrent pulmonary edema that I cannot explain, it seems disproportionate to their lung disease. If there is a left to right shunt that I feel may be contributing to the clinical phenotype, if the child is not growing well despite being on high fortification and adequate feeds. Pulmonary hypertension is noted on echo, and I work on the ventilator with Neo, and I work on the oxygen and everything. And I think things are as optimized as they can be. We have the child maybe on nitric, maybe even on sildenafil, but the echo is still not getting better. And at that point, then I would think, well, perhaps there's a left heart component, or maybe there is a pulmonary vein component, and we need to get to the cath lab to characterize that better. If there's right heart failure, it is unusual that significant right heart failure or persistent right heart failure is seen in a BPD patient with pulmonary hypertension who was otherwise well managed by their ventilatory and respiratory status. If it's a patient who was already on sildenafil, I'm thinking about adding a second agent, I would like to get a cath to make sure that what I'm treating is actually pulmonary hypertension, and then assess response to therapy by cath. So I started a patient on therapy and I want to see, is this therapy helping? Do we need to be on this therapy? And we can get a cath then. And then finally, if I'm thinking about pH, but I'm thinking about 5 other things too, I may move forward with a referral to cardiac cath so that we can truly make a diagnosis of pulmonary hypertension. Catalina, do you want to explain yours?
Yeah, thank you. So in our NICU context, I'm going to show some of the work done by Unified World, like the TNECO Quebec team, but normally they are kind of the same. Like if we have concern for PVS, as Nidhy says, like we talk about like a clinic like disproportionate to a previously diagnosis we knew, to evaluate the shunt, the contribution of the shunts. Also, like worsening or not improving despite ongoing management of pH. After an event, if we had a baby that had a suprasystemic pH, and then after we stabilize and one rescued, we will have to like have all the information with a formal cath, not just echo information. And then if there is a concern for LV functional alterations. So here, this slide is a slide that Gabriel shared with me. It's like the new algorithm they were gonna use at Montreal Children's Hospital. So if you see here, really just that the consideration for cardiac cath after evaluating a baby like at pH screening at 36 weeks equivalent, this is like the same. So concern for PVS, evaluating shunts, and also if there's worsening despite treatment. So here also, this is a work we did with Audrey Hebert from Quebec and Gabriel and me about BPD-PH. So there's also this information about when to consider cath. And as you can see, for us as neonatology, it's interesting that for pulmonologists, this about poor growth and recidivant like edema. So for us, is mostly evaluation for PVS, shunt, and mostly inadequate response. So there are more additional here, which is suspected aortopulmonary collaterals and at the discretion of multidisciplinary team.
When we think about pulmonary hypertension, and first thing that we need to do is we're suspecting it, we get the echo, and then we do get to the point that we think about cardiac catheterization, as Carolina just explained and reviewed, as well as I did. that we need to think about then, well, when we get to the cath, what are we looking for? How do we diagnose pulmonary hypertension? And this is done by cardiac catheterization. Outside of the NICU, this is the gold standard. And in the NICU, just because of challenges with transport that are inherent for the neonate or the unstable infant, cardiac catheterization is not always insisted upon in this population. But so this is hemodynamic characteristics, and this is really for children who are at least, it's ideally for 6 months of age and up, because by then you expect adult levels. And so this is how pulmonary hypertension is diagnosed in the cath lab, and these are our data. So we have pre-capillary, we have isolated post-capillary, and combined pre- and post-capillary pH. And as you can see, the definition of pulmonary hypertension, or rather the diagnosis, doesn't rest just in the mean PA pressure. It rests in the mean PA pressure, the relationship with the pulmonary artery wedge pressure, and the PVR, and index, the PVRI. So really get a full picture of what the pulmonary hypertension looks like in this individual patient. If the pH is coming from the lungs, if it's coming from the post-capillary segment, or if it's a combination of both. Next slide, please. And so when cardiac catheterization is performed, it is important to always remember what your normals are. And so you guys can look at this as well as I can. And so just in the interest of time, I won't belabor this, but this is what a normal cardiac catheterization, what the expected numbers are. And this is what's here on your left. And normal is a mean PA pressure. We expect that for the diagnosis of pulmonary hypertension for it to be less than 20. And so if it's greater than 20, we are concerned. If in that by itself may not be enough to diagnose pulmonary hypertension, you need a wedge pressure that's normal, a PVRI that's elevated. And then, of course, if it's a post-capillary, the wedge pressure will be also high, and your mean PA pressure will be high, and your PVR would be elevated. So looking at this, it gives us so many clues in the cardiac cath to tell us where the problem is so that we can be most effective with our medications, with our interventions, and overall with the therapies. And if you look at the one here to the right, this is not a neonate. This is just a sample cardiac catheterization that I use for the purposes of illustration. And this is an older child with pulmonary hypertension. And you can see that their mean PA pressure is 63, right? If you can see that written there in the main pulmonary artery branch. It's 63, the wedge is normal at 11, and the PVRI is 12.2. So this certainly meets definition for pulmonary hypertension and specifically pre-capillary pulmonary hypertension. Next slide, please. So what did we talk about though with post-capillary? So with post-capillary pulmonary hypertension, we want to take a couple of minutes and end up our talk just talking about pulmonary vein stenosis. And so PVS is it's a challenging diagnosis to make because the most common presenting symptom that infants will have is pulmonary edema. And for those of you on the call who are at the bedside of these neonates, you know that everyone's on Lasix, right? It just feels that way. Everyone's got some Lasix, everyone's got a little bit of leaky bed. And so pulmonary edema is not an unusual thing. So pulmonary vein stenosis can appear as patchy pulmonary edema that is anatomic. And what I mean by that is that you look at the films and you say, well, we increased the Lasix and the pulmonary edema looks better, but that right upper lobe just seems always hazy, right? And that would make you think that is there an anatomic abnormality in that right upper lobe that maybe predisposes to pulmonary edema? Or perhaps there's diffuse pulmonary edema and you're thinking, this kind of seems disproportionate to the, degree of lung prematurity this patient has, for example. And then screening. So echo, CT chest, these are ways that we think about pulmonary hypertension. And we think about like really getting more detailed assessment. On the echo, you're going to be looking for the pulmonary veins. Do they drain normally? Is there any turbulent flow that is visible? So, you know, these babies should have a complete echo at some point, which looks at all the different factors, anatomic factors that could be affecting cardiac performance. And if you're suspecting it, you should get a CT. And this would be a CT with contrast. And that would be looking at the veins, looking at the vasculature to really get a sense of whether there is an actionable gradient across the pulmonary veins. Cath is a gold standard. Once the imaging is abnormal, cardiac cath is what we use to determine what the pulmonary wedge pressures are to shoot angiography. And the interventionalist is able to give us a lot more information about the pulmonary veins in that way. And, I've been surprised. I don't know, Carolina, if you've had this experience or others too, that you might think that the echo suggests that one of the veins looks abnormal. You get the CT scan and you see, oh my goodness, it's a lot longer segment pulmonary vein stenosis than we realized. Like we couldn't appreciate that on the CT. And then they go in for the cath and they're getting angios done. And the angios show it's not just the right upper pulmonary vein. It happens, actually, there's a gradient here. Your angios are abnormal here. So you really, by looking at these pulmonary vein stenosis patients with multiple imaging modalities, it takes all of that to really get a nice comprehensive 360 picture. And that's, the majority, the crux of treatment for pulmonary vein stenosis is also the diagnostic modality, right? So treatments, the number one is catheter-based. So most of the time it's going in with the catheter, doing angioplasty, sometimes balloon dilations or stents, drug-eluting stents, and breaking and fracturing the stents and just widening them. So a lot of it is really catheter-based. But there are patients who have long segment or a disease that's not amenable to that. And so vasodilators may be used because now there's right heart hypertension. And vasodilators, if using with pulmonary vein stenosis, even with one vein, I have found that you cannot get away with vasodilators without paying for them with a diuretic. And so typically it requires some kind of diuretic, even if it's one vein. Like these are not free. You cannot use vasodilators for free in a PVS baby. Remodeling agents such as sirolimus, surgical repair for like a sutureless repair, and then finally lung transplantation for patients in whom the pulmonary vein stenosis disease burden is so great, if there's multi-vessel disease, or if perhaps a patient has such a severe extent of disease that's not amenable. Next slide, please. And so what are different reasons that babies get pulmonary vein stenosis? And so this is just a couple of risk factors that were written up in a recent paper. And there are genetic risk factors, there are developmental risk factors, and there's hemodynamic risk factors. Some of this may change over time. Some of this may actually worsen. Some of this may not be the same. And so where there are opportunities for us to affect risk factors is always very important for implementation of strategies to minimize contribution of these risk factors. Next slide, please. And this is, there are risk factors inherent to what we do in the postnatal setting for the baby with prematurity, such as chronic mechanical ventilation. This promotes intimal proliferation, and you have abnormal vascular growth because of inflammation to start with. So this is, unfortunately, there are a couple of things in prematurity that are kind of, you have to do them, knowing that the extent, or rather the result of what you do may end up with increasing risk factor for disease states such as pulmonary vein stenosis. And hypoxic and hyperoxic conditions may also have effects on the pulmonary vascular smooth muscle and elevate endothelin-1, which causes vasoconstriction. So the vasculature in prematurity by itself is already abnormal and in some ways kind of primed to then react abnormally and go on to react in a way that can cause more harm later on. Next slide, please. So BPD and pulmonary vein stenosis, they share a number of risk factors, which is why PVS is really more common in the preterm infant. And these consist of prematurity-related disruption in fetal development, poor growth, chronic mechanical ventilation, pulmonary vascular disease, systemic inflammation such as occurs with infection, and epigenetic mechanisms that we don't necessarily understand well. Next slide, please.
So yes, as Nidhy mentioned, there are many things like during the marathon, like we go in the NICU, because babies are exposed to many things and diagnoses that are very common. And then, as I mentioned before, they add up, like they are like an insult and another insult, and then we have a high risk with each of them. So I'm gonna go over like, this is the most recent paper I found on PVS, specifically on risk factors, and it's very interesting. So it's a really, it's huge. It includes like more than 10,000 preterm babies. So they found 109 cases. Sorry, I'm bad at numbers with PVS. So the prevalence was 1%. So as you can see here in the tables, like relative to controls, infants with PVS were more likely to be less than 500 grams, adverse to be small for gestational age, to have surgical neck, ASD, pulmonary hypertension, and in the multivariable models, this association persisted, and SGA and necrotizing enterocolitis and ASD were each independently associated with PVS. So there is very like interesting information on particularly necrotizing enterocolitis, because in this article it is mentioned that so pulmonary veins arise from the splagnopleural mesoderms via BEGF. Induced vasculogenesis. So this link has been done. It was very interesting to me. So this may also affect all other cells with similar embryologic origins, suggesting a broader vulnerability. So as I see, it's more like a systemic. To me, it's more like a systemic condition affecting certain cells in the same or pathways maybe in the same time. So aspiration has also been associated with 5 times greater likelihood of poor response to treatment. As Nidhy mentioned, one mechanical factor like the traction of the airway was mentioned. So it's very interesting. So I'm gonna go quickly just for the sake of time, but so it is really important that me as a fellow was really like the Crabio is not one of the easy ones. So I just want to encourage you to do it, and maybe just look at the Dopplers, because you're going to be evaluating longitudinally. Maybe it's not the best way to diagnose, but it is one of the first alterations you see is in the echo, maybe turbulence in the Doppler, in the envelope Doppler. So you have to get familiar with this. So I couldn't put video here. I will do in the case. But so this is these are the Dopplers, courtesy of NeoCardiolab, if you wanna take a look on this section. But if you can see, we see biphasic, triphasic Dopplers. So there are articles suggesting that we should take like a lower velocity to start to suspect of a mild stenosis. But before that, we can start as fellows or starting to do echo to see this biphasic or triphasic form, and then we can compare longitudinally, because it is said in the literature that sometimes 3 echoes before you don't see is like the average echo before seeing an alteration. So this one, I get it for a case presentation. I put it in the reference. It's very interesting because it shows a predilation Doppler of the pulmonary vein. You can see here how it doesn't return to the baseline, and then postdilation. So we can this like the form of the envelope Doppler is very valuable for us because it's like our first line to suspect PVS.
Thank you. So it is so challenging because these patients, you really have to be able to identify on echo. So, these abnormalities, and some of them may be very subtle, like Carolina said, and many of them can be user dependent based on the window that you get, how well you're able to image it, the cooperation of the baby, all of those things. But with echo, you're able to sometimes get some additional information that at the bedside may not be as apparent, right? So you may have one baby, a BPD infant, and at the bedside shares a lot of features with a PVS baby. And there could be a lot of BPD infants who have both, who have BPD and pulmonary vein stenosis. So BPD infants tend to be, they need respiratory support. They're frequently have respiratory distress, they may need oxygen, they may be trying to wean respiratory support, but in fact, they actually need to increase respiratory support. They might be dependent on diuretics and have frequent hypoxemia. And as you can see, the pulmonary vein stenosis infant will have many of those same characteristics. And this is where maintaining a high level of index of suspicion, understanding risk factors for pulmonary vein stenosis, and knowing when to really think about pursuing a PVS diagnosis is what's going to be helpful to differentiate between these two diseases at the bedside. So one other form of postcapillary pulmonary hypertension that we thought we would mention here that is seen in the NICU is congenital diaphragmatic hernia related PH. And when we think of, I always love kind of juxtaposing BPD and PH and CDH because both are developmental lung diseases and both are conditions in which there is a degree of alveolar simplification. But BPD is a condition in which pulmonary hypertension may occur as a complication as over time, sometimes in association with pulmonary vein stenosis, most of the time not. Whereas in congenital diaphragmatic hernia and CDH, these babies are born with pulmonary hypertension. They have it because their vasculature was so abnormal in utero, because their pressures remain high, and then over time, as their pressures drop and the lungs are recruited, expanded, etc., pulmonary hypertension typically gets better. But now there's a lot more interest and understanding that pulmonary hypertension in the CDH population, that PH may not all be this pre-capillary developmental lung disease related PH, and that there may be underdeveloped left heart and underdeveloped left cardiac structures contributing to the pulmonary hypertension. And that is, of course, challenged because in this box, the three other reasons to have pulmonary hypertension in CDH are related to pre-capillary issues. And we'll give you a pH that is truly amenable to pH therapy. But in the CDH population, underdeveloped left heart and cardiac structures is an increasingly recognized source of pH. Next slide, please. Next slide. And this, I'm sorry, I don't know, my references are not coming through. But so for this one, this kind of shows why these changes occur over time. So in normal fetal circulation, as you can see, the blood flows in, it flows out. It's got, it's kind of got this nice return, and the blood is, the left heart is able to somewhat participate as it's kind of expected, but it's able to grow. But in fetal circulation in congenital diaphragmatic hernia population, the left heart is often compressed by the hernia. And this can be the case even in a right CDH or left CDH. The left heart may have some compression just because there is shift of so many structures in the chest. And so the left heart, even though there's shunting of blood preferentially, the left heart may still be somewhat compressed and not be able to grow the same way. And then as the baby transitions from prenatal to postnatal life, during that transitional and perinatal period, the left heart compression becomes really profound. Becomes a lot more profound because now the blood is now no longer returning. It is actually needing to flow through the left side of the heart. The left heart now sometimes can't do it. It just can't flow the way we expect it to flow, and it cannot keep up with the demands for cardiac output. So this transitional circulation in CDH may actually persist longer than people recognize, and there may be continued left heart involvement that can contribute to right heart abnormality.
Sorry, I just click on the
image.
Yeah.
Okay, go ahead. Next slide, please. And so imaging for the CDH baby on X-ray, when you would suspect that there's a postcapillary issue, would be very similar. It's pulmonary edema on a chest X-ray. And a CDH baby, and especially if they're on ECMO or they're getting a lot of fluid resuscitation, those can all be reasons that you have pulmonary edema on chest film. But when it seems disproportionate to what you're giving, seems disproportionate to the eyes and nose, for example, then pulmonary edema related to a post-capillary phenomenon should definitely be considered. Screening is going to be, again, consists of echo and CT chest. Cath is unusually done. Right? So we're not necessarily taking all the CDH babies to the cath lab, but again, only if there is a concern or a reason to take to the cath lab. That was reviewed earlier by Catalina and by me. Treatments are more or less the same, catheter-based treatments, vasodilators if you need them, and you can pay with diuretics. And then this time it's afterload reduction. So we're not really looking at in this population like remodeling agents like sirolimus, but we're looking to see like if this left heart, is it just small left structures, or do they have an aortic abnormality? Do they have a small mitral valve, et cetera? So there may be other things that can be contributing to your picture. Next slide, please. Oh, that's our references. Okay. So those are, that is a quick overview of a lot of information. There are a number of references that we have here if you'd like to read more. Some of these references were used during the presentation also for pictures. So I know, Danielle, that we are really over time, so I apologize, but we're happy